ladies and gentlemen. Today I'm going to complete the question raised by my colleague, Dr. Muhammad, regarding his patients. So, after defining the case as drug-resistant epilepsy, should we try other anti-seizure medication or move to pre-surgical evaluation or trying other non-pharmacological and non-surgical options? There is different pathways, but always and always the patients and their families are concerned when the term surgery is mentioned. So, moving to pre-surgical evaluation carries both advantages and concerns. It has the advantage of rendering the patients, highly selected patients, seizure-free. However, patients and their family are always concerned because of the unfamiliarity of the procedures, particularly in countries with limited resources. Also, the cost of epilepsy surgery and the pre-surgical evaluation is another concern. Complexity of the pre-surgical evaluation, tomophobia, where the patient and their family are concerned about the operative procedures and possible complications. Lesions, when lesions are close to or near to eloquent cortex, and in cases with non-lesional drug-resistant epilepsy. Also, the lack of adequately trained surgeons, particularly in limited resources country, is still another important part. The availability of less invasive solutions make the patients take the decision slightly away from the surgical option, and the value of epilepsy surgery in epileptic encephalopathy is still another concern. So it's always a matter of tailoring the decision according to the individual risk-benefit analysis with proper explanation of the pros and cons of each pathway. As we mentioned, pre-surgical evaluation is complex, and availability, expertise, costs, and time also are major concerns for the family and their members. Also, the risk to induce seizures in the epilepsy monitoring unit with the possible complications is another concern. Epilepsy surgery is not without complications. Complications include both surgical and neurological. And this is also related to the complication of intracranial monitoring. Also, in cases where epilepsy surgery is carried on lesions near or in eloquent cortex, there is a major concern for injury and potential post-surgical deficit. Also, not all the patients will be seizure-free post-operative, and this was illustrated in the ENGEL and the International League Against Epilepsy classification of post-surgical outcome. Also, even in cases with temporal lobe epilepsy, still not all the cases will be drug-free or will be seizure-free post-operative, and this depends on the location of the epileptogenic lesion, either in the mesial or the lateral temporal structures, the presence of dual pathology, or the coexistence of bilateral pathology. Sometimes we need to do a staged surgery with two stages of surgery, or either surgery and the insertion of a responsive neurostimulation. The long-term outcome of epilepsy surgery is not complete seizure freedom in all patients. And this is particularly important in cases with extratemporal pathology. There are many factors that influence the post-surgical outcome in patients with drug-resistant epilepsy, including the finding of lesion in MRI, the presence and the location of the lesion, and the pathology of the lesion with mesial temporal lobe sclerosis carrying better prognosis than patients with focal cortical dysplasia, particularly type 2. Also, the presence of learning disability and multiple anti-seizure medication trial prior to initiation of surgery with older onset at epilepsy onset carries also a worse prognosis. Also, the performance on surgery in patients with extremes of urge is another concern, with patients in the old age carrying a major perioperative, a higher risk of perioperative complications, and patients in the younger age group carrying concerns for their family regarding their long-term outcome. So at this stage, we should stop, rethink, and replan. Should we move really to surgery, or should we try adding other anti-seizure medications or moving to other non-surgical and non-pharmacological patients? Also, at first stage, we should revise ourselves. Is it really drug resistant? It might be a wrong diagnosis, wrong drug, or wrong dose, or related to lifestyle issue. And we should always discuss the principle of treatment with patients and their family. Also, the problem with documentation of the long history of the patient, the long journey the patients with epilepsy carry, particularly in our country, is a major point of concern, as documentation is not always available. Kwan in this paper discussed the importance of trying additional anti-seizure medication or going directly to epilepsy surgery. And they mentioned that fluctuation in response to anti-seizure medications and also the development of new anti-seizure medications and the elimination of lifestyle factor might render the patient seizure-free or even decrease the burden of seizure occurrence among patients with drug-resistant epilepsy. And thus we can have subsequent remission with further adding anti-seizure medications compared with surgery. And also we should revise ourselves regarding the potential risks of epilepsy surgery. The armamentarium of anti-seizure medications is expanding with the development of new anti-seizure medications and anti-epileptogenic medications also. And this carries a hope for patients with drug-resistant epilepsy. Also, the availability of non-pharmacological options such as neurostimulation and dietary therapy carries a better hope for some patients. In this famous graph, we always used to go try to push the patient to epilepsy surgery or convince the family with epilepsy surgery. It was found that adding the third anti-seizure medication will only carry a little chance of rendering the patient seizure-free. However, still there is a chance. And also, with the previously mentioned risks of epilepsy surgery, maybe we can revise ourselves. The management of drug-resistant epilepsy with pharmacological options should address all these points for rendering the seizures drug-resistant. And that's why the anti-seizure medications development take into concern the multiple points where anti-seizure medications can act, either on the channels, the ligands, or in the postsynaptic membrane. For example, cinupamate was found to be a very successful drug for management patients with focal drug-resistant epilepsy. It's a sodium channel blocker, but it acts on both the slow and fast inactivated sodium channel. And it was found that it can be an attractive option for the treatment of drug-resistant focal epilepsy. Also, pyrambanel, which acts on the AMPA receptors, was found to be a successful option for patients with drug-resistant epilepsy among both adults and the pediatric age group, particularly if we started at lower dose in a trial to minimize the possible adverse events. Also, cannabidiol was found to be a good option or sometimes an alternative treatment for patients with some cases of epileptic encephalopathy. However, the issue of tolerance is still a concern. Other drugs such as the brivaceritam was found to be an add-on therapy, a successful add-on therapy for patients with drug-resistant epilepsy, minimizing the behavioral side effects of its precursor, the levetiracetam. Other sodium channel blockers such as the oxcarbazepine and lacosamide were also found to be successful for managing some focal drug-resistant epilepsy in a trial to avoid epilepsy surgery. But what about all the anti-seizure medications? In this nice study, it was found that patients with drug-resistant genetic generalized epilepsy, the term drug-resistant genetic generalized epilepsy should not be implemented unless valproate should be used. Also, the advantage of adding lamotrigine to sodium valproate was found to have some advantage in rendering the patient less free of major epilepsies and also in improving the cognition. Topiramate and zonisamide are both good options for patients with focal drug-resistant epilepsy. And currently, there is a lot of work being done for development of anti-epileptogenesis and disease-modifying therapy, taking into account some major points of the pathogenesis of epileptogenesis, like such as the anti-inflammatory agents, the mTOR inhibitors, and the BDNF gene therapy, and the other ligand therapies. So for some patients who are not deemed to proceed with the pre-surgical evaluation, enrollment in the drug trial can be still an option. The management of patients with developmental and epileptic encephalopathies are also a major concern, because epilepsy surgery in such cases where no identified lesion which can explain the multiple seizure types in these patients would not render the patients completely seizure-free. It's just a palliative epilepsy surgery. So the main front in such situations is on the pharmacological treatment, but taking into account the anti-seizure medications and the other drugs such as steroids and other immunotherapy. Other non-pharmacological interventions that can be used for patients with drug-resistant epilepsy includes ketogenic diet and the neurostimulation, and both can help the patient to decrease the seizure outcome, trying to avoid the adverse events of epilepsy surgery, and trying to create some hope among patients with epileptic encephalopathy. At the end, it's all a matter of customization. We should customize our decision according to the patient's story, the patient demands, taking into account the requirements of the patient and their family. Thank you.